Hi, everybody. Can you take your seats, please? We're going to begin.
Good afternoon, everybody. My name is Ayman Al-Mohandes, and I am the Dean of Public Health at City University of New York. And I must admit that this is a moment to rejoice. A moment to rejoice in achievements of a great man. A moment to rejoice that at times the documentation of important historical events is manifest to people that would like to learn from champions. There couldn't be a better platform for us to be assembled today than City University of New York. I pride myself in being a dean at City University because City University stands for social justice with 275,000 students, degree earners, and another 265 continuous learners. We have approximately 550,000 students. For every 2 learners walking the streets of New York, one of them is a student at City University of New York. But that's not what I'm proud of. Big is great, but just is beautiful. City University of New York today, 60% of our students pay no tuition, and 80% of our students graduate without debt. Now that is beautiful. The number of undocumented students, undocumented immigrant students in City University of New York exceed 1/3 of the total number of students at Columbia University. The results of the elections in the past week could not be more relevant than what we are assembled around today and where we are assembled and the man we are assembled around and the topic we are about to embrace and entertain. At moments like this, we have one of only 2 options. Either to give in or to dig in. The story of Jack preceded his well-known history in the United States and started with a couple, Sidney and Emily Clark, in South Africa, that decided that serving a community meant that you needed to partner with a community. And with the advent of apartheid in South Africa, this concept in of itself, that partnering with small communities in African villages in KwaZulu-Natal, very specifically a little village that I visited called Polela, was considered politically subversive, up to an extent that Sidney and Emily became enemies of the state, had to flee South Africa, and immigrated to Israel at that time. I will not tell their story, because their story has been told. But what is important for us to know today, that standing for justice and understanding the perspective of health as a core element of what justice is not a marginal issue in this day and age. And in our digging in, we will be inspired by those that came before us and dug in. And no one dug in more than Jack. when nobody even thought of concepts that he applied. Nobody understood partnerships that he initiated. Nobody believed in successes that he manifested. He dug in. And when Tom selected to write that important book, he knew that this was something that was so worth documenting. We are proud at the School of Public Health at City University of New York to stand behind you, to stand with you, and to dig in side by side with those that know that our cause is just, that truth is manifest, and that honor is in persistence. Welcome here. I hope this is going to be worth your while, but I suspect that it will. Thank you.
Dean Mohandas, thank you very much. Good afternoon, everybody. I'm Fagala Jacobs. I'm the president and CEO of the RCHN Community Health Foundation, and it's my distinct privilege to welcome you here today to this celebratory event, the launch for Out in the Rural, a Mississippi Health Center and its war on poverty. What I really want to do while I have your attention is to say thank you. Because especially in these very dark days, I think that it's especially important that we acknowledge the forces of good in this world. And there are a great many of you here today, and I'm really grateful for your presence. So first, I'd like to thank Dean Mohandas, first of all, for bringing the School of Public Health to Harlem, to 125th Street, and for staking out for CUNY this space at this time, which I think is just extraordinary. So I'd like to thank him for bringing the school here, for opening the doors at the CUNY School of Public Health to us today. And I'd also like to thank Barbara Aaron of his staff for all the work that they did to put this event together. Of course, without our esteemed honorable guest, Dr. Jack Geiger, the Community Health Center movement as we know it today simply would not exist. And undeniably, Dr. Geiger is the father of our movement. Absent his vision, his commitment, and his struggles, as well as those of the late Dr. Count Gibson and Dr. John Hatch, we would not be here today. So it's really delightful to welcome Dr. Geiger, to welcome Dr. Shumph along with him. Thank you so much for joining us today. Of course, we owe a debt of gratitude to Dr. Tom Ward, who's our author, who has come a long way from Spring Hill, Alabama, for seeing just how important it was to bring his historian's mind and eye to researching and telling the story of the Tufts Delta Health Center. His book is an extraordinary contribution to the social and political history of health centers. We are delighted to welcome him, his father, Dr. Tom Ward Sr., his wife, Margaret, his son and family. So thank you for coming and for helping us develop this program. Oxford University Press brought the book into the world. They made it possible for us to offer it today at a discount for people to purchase at the end of the event, and we thank our Oxford colleagues. I also want to thank the board of my own organization, RCHN Community Health Foundation, for supporting this project. Joining us today are Dr. Monica Sweeney, who you'll later hear from as panelist. One of our former board members, Dr. Sam Daniel, I'm not sure that he has entered yet, but we're expecting him to join us today. And our immediate past chair, Dr. Sarah Rosenbaum. In her day job, Sarah is the professor and founding chair of the Geiger-Gibson program at the Milken Institute School of Public Health at GW, George Washington University. She was absolutely instrumental in securing the funding that got the research done, in administering that funding, and in supporting this book. So thank you as well to Sarah. And finally, I really want to thank everybody in the audience for taking time on a Thursday afternoon, the week after an election, who have come together from health centers, from academia, the policy community, and the public health community. I think many of you feel as I do that these have been especially dark days, and I genuinely appreciate the commitment and the interest of everyone in this room to learning from our history, to hearing Dr. Geiger, to hearing Dr. Ward and our panelists, and to working together to help nurture health, health equity, and healthcare justice. So I'm going to now turn the stage over to Dan Hawkins. Dan is Senior Vice President of Public Policy and Research. Those of you who don't know him should. He's from our sister organization, the National Association of Community Health Centers. And of course, Dan, at the helm of the policy division of NAC for the past many, many years, has made possible the work that health centers do, and we're really gratified, Dan, to have you here today. So, Dan, thank you.
Thank you, Fagel, and good afternoon to everyone. Wow, full crowd. I hadn't looked back since I first sat down. Wonderful to see you all here for what I think is a significant marker along the timeline and life of community health centers. There are so many people in this room who deserve thanks and appreciation and admiration for the work that you've done over the years to keep healthcare access for low-income populations, both urban and rural, across this country, to make it more available. You know, most everyone here knows that last year we celebrated the 50th anniversary of community health centers. And over that time, a lot has happened, and a lot has been grown, or has grown rather. And it's amazing what has been accomplished since Dr. Geiger and his sidekick, Dr. Count Gibson, first spun out the idea of community-owned and operated systems of care in Boston and Mount Bayou back in 1965. The path for health centers over the years, over the past 50 plus years, has never been easy. But, you know, despite setbacks from time to time, they have continued to grow in numbers of people served, to grow in the breadth of services being offered, and to grow, most importantly, in the appreciation of not only the 25 million people who rely on them for good quality care today, but the millions of other people in communities, in those 10,000 communities across America, where the health centers are located and where people are getting care and living longer lives, healthier lives, in a more robust community network as a result. You think about it, it took 35 years for health centers to reach the first sort of milestone, 9 million people served in the year 2000. 35 years to get there. Yet 10 years later, health centers had doubled the number of people served, 18 million people in just 10 short years. And now, late this year or early next, health centers will surpass 27 million people served. Another, 9 million, so 9 to 18 to 27 million in 6 short years. The timeline collapses, the growth gets bigger. And that is absolutely wonderful. And I will tell you that we know, I had people at my arm earlier this week wondering when the federal funding agency is going to announce the funding of the next set of health centers, which they had invited applications for last summer. And I'm not even sure that's going to happen after last Tuesday, this past Tuesday. But we're hopeful it will. Here's the point. The need and desire on the part of communities to open and operate a health center has not waned one iota since day one. There have always been, throughout the entire 8 years of George W. Bush's presidency, and we're proud of the fact that we have bipartisan support and that we were a favorite of President George W. Bush. There's a lot of other things he did that we can take issue with and probably strongly oppose. But this is one thing he did, and I will tell you, he kept faith with it through the 8 years of his presidency. And that's, I think, an important thing, that we have attracted support from both sides of the aisle. That's something that I work hard at to keep that way. It's never easy. But it's so vitally important because it's been a measure of our success. And during the 8 years of George Bush's presidency, every year he requested an additional amount of money. This was not mandatory funding that grew automatically. He had to request it, Congress had to provide it. And each year, his budget would request some more money. And there were a couple of years when Congress short-funded him. And don't you know, the next year he came back and added the shortfall to the next year's amount. One time, Congress overfunded health centers, and don't you know, the next year he came back with a budget that reduced the amount that he was going to ask for in the following year. Here's the point: after 8 years, health centers were exactly where President Bush wanted them to be, both in terms of dollars and in terms of people served. And that was a measure of their work and their success. Today, they're the healthcare home for 1 in every 13 Americans across the country. And they're a living testament to the dream and the vision of their founders, Jack, Count, and others like him, some of whom are in the audience here today as well, who saw a system of care in their dreams that would be healthcare of the people, by the people, for the people being served. No place else in our American healthcare system is there anything that matches that, okay? Where the people being served, and I worked for a community board in Deep South Texas back in the early 70s, and I know, and I look at Ann Nolan, we both know the agony and the ecstasy of working for a community. When you make a wrong move, they don't let you forget. Here's the most important point. In those systems of care, in those community health centers, the community determines what services are going to be offered, what hours they'll be open, how they will treat people who don't have the ability to pay, et cetera, what care is going to be given, et cetera. Those are the most important things in the delivery of care. The quality of care is important, Jack, I'm sure would agree, but not only the quality, but the way in which the care is offered is vitally important. And toward that end, we are thrilled to have Dr. Tom Ward Jr. here with us today, who is chair of the Department of the History Department at Spring Hill College in Mobile, Alabama. Tom, you're a native of Annapolis, just down the road from us in D.C. Glad you didn't move into D.C. That tends to taint everything. But Dr. Ward earned his PhD in American history from the University of Southern Mississippi. So you may have been a native of Annapolis, but you're a Mississippi kid now, pretty much for your life. He's the author of numerous books, including one that preceded this, called Black Physicians in the Jim Crow South, published about 10 years ago. But the book we're here to celebrate today, Out in the Rural, celebrates that nation's first rural community health center and its groundbreaking mission to provide medical care to thousands of people who otherwise would have no care whatsoever, and to do something else. And Jack always reminded me of this, to be an instrument of social change. Not just to be an instrument of care, but an instrument of change. And that is so important. Dr. Ward's chronicle provides portraits of Jack and other founders of the clinic. We consider Jack the godfather of community. Well, Ted Kennedy, I think, is the godfather, Jack. You're the father. You're the immediate father of community health. And people like John Hatch and other organizers who endeavored against significant odds amid skepticism from the local community, both black and white, to organize healthcare for the poorest. A story that is as urgent today as it was half a century ago. And so we asked Dr. Ward to please come up and regale us with a few inside stories from the history.
And thank you all for having me here. This is very overwhelming in many regards, and thank you for Johannes and Fergala and everybody that helped put this on. I came to this project a couple of years ago. A historian by the name of John Dittmer, who's known Jack for years, who was a professor at Tougaloo University, then Tougaloo College in the 1960s, and had been involved in the movement, and had written a book on the Medical Committee for Human Rights, of which Jack was a member of. And John called me and said, I want you to think about writing a book. And I said, well, John, I'm I'm doing something now. I'm in the middle of another book, and I said, I'm not taking on anything new. I got young kids. And he said, no. He said, you need to write this book. He said, it's about my hero. He says, about Jack Geiger. And he said, this book needs to be written. And he says, I can't do it. And he says, I need you to do it. He goes, you're the person. You're from Mississippi. You've done healthcare. And he says, you need to do it. And a couple weeks later, I met with Jack. And after I met Jack, as I assume everybody in here knows Jack and has met Jack, then it became something that, you know, I had to do, because as you all know, Jack is as inspiring a person that there is, and this is a story that needed to be told. So one of the things I love about this story is that I know all of you or most of the people here, of course, are healthcare people, but it's richer beyond just healthcare. It's about a lot of things. It's a civil rights story. This book and the Mound Bayou Project came out of the civil rights movement. Jack was involved in the civil rights movement as a member of the Medical Committee on Human Rights. Elsie Dorsey, who we'll talk about, is one of the great heroes in the movement in Mississippi that not everybody knows of. She was one of Fannie Lou Hamer's lieutenants on the ground, and just somebody who had more guts and more drive than so many people put together. Bob Smith, who we're going to talk about, a physician. Aaron Shirley, John Hatch, all these people were part of the movement. And so the health center, comes out of Freedom Summer, comes out of what went on in Mississippi, and it also came out of a lot of the frustration. Jack and Bob Smith and Aaron Shirley were members of the Medical Committee for Human Rights, which was basically a group of doctors that went around and followed the civil rights workers around, patching them up, because local hospitals, local physicians would have nothing to do with them. They would get beaten, and they would, they'd be left on the side of the road. So you had doctors like Jack, like Aaron Shirley, like Bob Smith, but they got frustrated because they would see these protests for voting rights, especially at this time in '64, for equal rights, and then they also saw the extreme poverty of what was going on, and a number of them started to question, well, what are we doing? Why are we working for voting rights and access to public facilities when people are so poor and so unhealthy? And Bob Smith, I've got well, here we go. Where's Bob? Bob Smith, who's still around, and a number of people in here know Bob. Bob's a great character. He was a member of the Medical Committee for Human Rights. He was the leader of the MCHR in Mississippi. He's a Black Mississippian. He's from Jackson, and he got horrified by what he saw. I kind of love this quote. I don't usually like to read off PowerPoints, but this one is just so strong. Bob said, and he said, I understood for the first time what it truly meant to be Black in Mississippi, and underprivileged and poor without medical care, and saw people by the hundreds and really by the thousands go without medical care. Saw what I call a third world country. People had been denied benefits under Social Security. People have been denied benefits for welfare. 30 to 40% of the children had intestinal parasites. The maternal mortality rate was out of this world. And he's from there. He wasn't somebody coming down from Boston or New York. And there were, of course, many of those doctors were horrified by what they found. But Bob was horrified. And so there was this meeting with Jack and Bob and Aaron Shirley and Count Gibson. And they say, what can we do? And this is where Jack proposed his idea because of his experience in South Africa, his experience with the Karks, of a community health center. And they first started a small clinic, the Millston Clinic outside of Jackson, but eventually they said we need to do more. And of course, at this time, you have, kind of fortuitously, the beginning of the OEO. And so Jack said we need to do more than just figure out how to make people better when they're sick. We need to figure out how to deal with the problems that make people sick in the first place. These social determinants of health. And he said, until we do that, nothing else is going to matter. Until we can figure out how to fix the problems on their most basic level, having to go in and put Band-Aids on, give medicine after the fact is not going to do us any good. So Jack proposes that the MCHR, he and Count Gibson, apply for first basically just a demonstration grant. They want to, I think the original amount was $30,000 to go and find out if this would even be feasible. The OEO, Lyndon Johnson's War on Poverty, which had initially not saw healthcare issues on the ground as being, of course, Medicare and Medicaid was a main part of the War on Poverty, but doing things on the ground like Jack was talking about was not originally a focus. Jack and Count Gibson go make this proposal, and they are approved to put in one urban center in Boston, in Columbia Point, and one rural center. And they didn't specify where it was going to be initially. And Jack looked around at a number of places. He had a couple of ideas of where he wanted to put it, but eventually they're going to settle on Bolivar County, Mississippi. And I don't know how many of you have been to Mississippi, but Bolivar County is way up in the Delta. It's actually very, very beautiful. If you've ever been to the Delta, especially when the cotton is in bloom, it's kind of magnificent to see. Incredibly flat, beautiful area, but also extremely poor. And so Jack and Count Gibson choose Mound Bayou, Mississippi. They chose Mound Bayou for a couple of reasons. One was, of course, the poverty of the area. It was an easy place to say, this is an area that is being left behind. This is an area with not enough money. The maternal mortality rate was out of this world. The infant mortality rate was out of this world. Right? But they also had another advantage, and this is where Mound Bayou came in. Mound Bayou was an all-black town situated in the Delta. It was an all-black town with an all-black government, and had been since the 1880s. It was actually a town originally founded by former slaves of Jefferson Davis's brother. Jefferson Davis, when the Civil War was over, he granted some land to some of his favorite slaves, and they founded the town of Mound Bayou. And so Mound Bayou had this history of black autonomy. Jack thought this was a place where there would be great protection, and in some regards there was going to be protection being there. It had the advantage of not one but two hospitals, Taborian and Sarah Brown Hospital, and so they thought that this was going to be a great spot. There were going to be some advantages to it. There were also going to be some disadvantages, as Jack would find out. So as Columbia Point was founded, they also began to make the plans for Mound Bayou and start to get things ready. And there we go. And here's Jack. There's Jack and John Hatch overseeing the building of the health center in 1967. Jack would bring on John Hatch. John Hatch is one of the other founders, really, of this movement. And I wish John could be here. We're hopefully going to do something down in Chapel Hill where he can be there. But John's going to be the community organizer and kind of a fascinating guy in his own right. Jack sends him down to the Delta to kind of lay the groundwork, get people organized, get people interested in what the movement's going on. And so I'm just going to read a little bit here. Upon arriving in the Mississippi Delta in the fall of 1965, Hatch did not first set up to community organizing, as he had been doing in Boston, but instead tried to integrate himself with the local population in the best way he could think of. I'd not lived in the rural South for over 15 years. I thought it useful to reorient myself to patterns of interactions and thought in a rural farm worker environment, Hatch recalled. So he lived with sharecropping families in plantation shacks and joined cotton picking crews in the Delta. After picking for half a day, my hands bleeding, back aching, and vision blurred, I picked 80 pounds of cotton. This woman, twice my age, had picked 150 pounds and seemed fresh as when she began at 7:30 a.m., he remembered. Hatch was so out of touch for so long that back in Boston, Geiger began to worry about his safety. But Hatch's experiment was successful in that he had abundant time to speak with the farm workers about their economic and health situations, even if they often questioned why he was there. They were curious about me, he remembered. Most doubted that I came from Boston and Mississippi to learn about social change. Several thought I was running from personal trouble up north and needed a place to hide. Along with working in the cotton fields, Hatch spent several months living with poor black residents of the Delta, sharing not only their work, with their social life along with their everyday problems. Experiencing diarrhea in a crowded rural home without toilet facilities is considerably more impressionable than reviewing data on the high rate of intestinal disorder, its probable cause, and the statistical fact that 90% of the housing is dilapidated and without plumbing, he later remarked in a paper. I mean, those are the kind of things John did. John got in and he ingrained himself with the community and started to build these relationships that were going to be so vital if this program was ever going to work. And what he began to do, he went to what he called the gatekeepers, the traditional leaders of the black community, preachers, businessmen, school teachers, the local government. We said this is a town with an all-black government. They were going to be necessary in helping him develop relationships. But John also believed that it was really important to find voices and leaders from people that were not the traditional leaders in the community. He wanted to find people that had not always had a voice. And one of the frustrations he has is that there was often deference. Oh, go talk to my preacher. Don't, tell me what he said. I'll do whatever this person said. But John worked very hard to try to develop local leaders from people that had not normally been leaders, especially amongst women. One of the ways he did this was he would set up committees. And he said, most of the committees, the preachers always wanted to be the head of the committees. And he said, so I started setting up, prenatal committees. And he says, the preachers didn't show up for any of the prenatal committees. And he said, so then I got some leaders. And one of the leaders that was really important to him and proved to be very important is Miss Pearlie B. Robinson. I've got a quote from her there, but I'm going to read a little bit of kind of John on Miss Pearl, if I can find it here. Here we go. So Pearlie B. Robinson, or Miss Pearlie as most people called her, was from the tiny hamlet of Round Lake, about a mile from the Mississippi River. She was maybe 5 feet tall and maybe weighed 250 pounds, close to God, remembered Hatch. A very bright person, but not lettered, and as was the case of many people in the Delta at that time, Pearl was a sleeper, a likable community activist who could speak to anybody and do it very well. Hatch first came into contact with Miss Pearlie at the Health Association orientation meeting in the town of Gunnison. She stood up and said, "You people say you want to hear what our needs are and start where we would like to start, but then you talk about babies all the time. What's happening in this community is old people who expected to be nurtured by their families. Those families are in Chicago and St. Louis and Detroit, and our old people are being neglected." Her message was not what Hatch and the other members of the health team had expected, but it was exactly what they wanted and needed to hear. The real concerns of the members of the community, not the concerns that the leaders of the Tufts Delta Health Center had brought with them from Boston. Miss Pearl got it, recalled Hatch. She understood the rhetoric. We want to start where you are and all that stuff. Hatch responded to her appeal at Gunnison and at other health association meetings that something had to be done for the elderly in North Bolivar County. While the center's initial goal was to deal with children and infant mortality, he later wrote, concerns from the community like those of Miss Pearlie B. forced the center to adapt and to expand the types of services that it needed to develop and provide. The position of coordinator of services to the elderly was therefore created at the Tufts Delta Health Center, and Miss Pearlie was hired to fill the position. I think this is such a great example of what the center did, how it had to learn and adapt, and as John said, tell us where you are. I mean, that's the idea of the community health center. It's not that we're going to come in and do what we think is best for you. We're going to come in and find out what needs to be done. And of course, John being able to bring in someone who was basically telling them, you're not doing what we want, and say, okay, we're not only going to do those things, we're going to bring you in and you're going to run these things. And she's going to be one of the the real gems of the movement early on in bringing in lots of other people to get things working. There was initially a focus, of course, on child welfare, but one of the things, of course, that happened, and many of you probably know this through the stories of Jack, is that there were lots of other problems, not only problems with older people, like Miss Pearlie brought up, and there are stories of a lot of the doctors Jack had brought down a number of pediatricians, and all of a sudden these pediatricians had to go back kind of and look in their medical books and start figuring out, how do they deal with geriatric diseases. A number of them talk about that. Say, I was going back to stuff I hadn't studied in years and years, trying to figure out how to deal with geriatric problems. But of course, one of the biggest issues was malnutrition. The malnutrition that they found in the Delta was absolutely devastating. And of course, until people could have enough to eat, they were never going to get healthy. And finding this malnutrition in the Delta, finding these problems, created a crisis for Jack and for others. And of course, this is where Jack came up with one of his most famous issues that I know is kind of inscribed with many people in the health center movement, but we'll talk about it a little bit. To combat the malnutrition crisis they found, Geiger and Hatch came up with an innovative solution, one that caused a great deal of controversy with both their federal funders and the Mississippi governor once they found out what it was about. The center's physicians began to write prescriptions for food. We decided that whenever we saw malnourished children, we would provide them with food. So much milk, so much eggs, so much meat, so much vegetables. We do it by writing them a prescription for food, said Geiger. A deal was made with one, then eventually 10 grocery stores in black communities in northern Bolivar County to fill the food prescriptions and send the bill to the Tufts Delta Health Center for reimbursement, which the health center paid for out of its pharmacy budget. It was a radical idea that Geiger had taken from his experience in South Africa, where Sidney Clark had provided dried skim milk to starving children, classifying it as medicine. When OEO got word that Geiger was buying food out of his pharmacy budget, it was incredulous. Geiger recalled his conversation with an OEO official. They said, "How could you do this? What do you think you're doing? You can't use a pharmacy for that." I said, "Why not?" They said, "Because a pharmacy is for drugs, for the treatment of disease." And I said, "That's right. And the last time we looked in the book for specific therapy for malnutrition, it was food." They went away because there was nothing they could say to that, something that was that stupid but true. Another physician at the center noted, if the mothers and babies don't eat, all the medicine in the world won't work. And the food prescription program would be something that, we're going to talk a little bit more about food in a minute, that will eventually be integrated in and budgeted precisely for this. But this, this idea, once again, that the community health centers having to go to the problems that they found, that you can't just go in and try to treat someone who's sick if they're malnourished, that they're never going to get better in many regards. The nurses at the health center are going to be on the front lines of many of the things that were done at the Tufts Delta Health Center. The center's in Mound Bayou in the northern part of the county. The center was going to focus on just the northern half of Bolivar County, but it was a very broad and very rural area. And so nurses were going to be vital in kind of being the eyes and the ears of the Tufts Delta Health Center in many ways. One was they were the ones that were going to be out there, sometimes dealing with people that couldn't get to Mound Bayou, bringing in aid on a daily basis or a weekly basis, but also finding people that they saw were in such a bad position that they say, we really have to get you to Mound Bayou. And I'm just going to read once again just a little section about the nursing programs that were going on. I've got a quote up there too. We can kind of have that up there as well. Thelma Walker stated, simply getting to the poor and scattered population in the rural area was the most significant difference from her previous nursing experiences, because dogs, dust in summer, mud in winter, and distances slow us down. The dirt roads of rural Bolivar County were sometimes impassable when the rains came and turned them into mud, or were full of deep ruts when baked by the Mississippi sun. Flat tires were a regular occurrence, and the nurses often had to park far from the patient's home and walk to the house, carrying all their equipment with them in order to save their vehicles. Walker also said that in the Delta she saw more mothers with toxemia and eclampsia, more children with rheumatic fever and diarrhea, more people of all ages with iron deficiency and anemia, and more elderly persons with ankylosing joints followed by cerebral accidents, than she ever had seen in previous experiences. She also remarked, however, that we also have more resources right at hand in the center and the community hospital than I've ever had too. So then, the nurses are going to get out there. They're going to be the eyes and ears of the center, and they're going to be the eyes and the ears of the center, not just for medical issues, but one of the things that's going to be, was one of the very innovative parts of what Jack and his team did, was dealing with environmental issues. Jack is going to hire Andrew James to be the Director of Environmental Services, and just like we talked about, you can't make people better if they're malnourished. You can't make people better if they lived in environments that made them unhealthy. And one of the first crises that Andy James noted when he came to Mount Bayou was problems with water. I'll just read a little bit from Andy here. And Andy James is still around, just a wonderful man. Access to clean water was one of the most pressing issues confronting the black communities when James arrived in Mount Bayou, and it had a direct impact on health. They were losing babies here because of the infectious diarrhea and bad water, he recalled. At that time, only 29% of the black population in Bolivar County had piped water. Instead, they relied on pumps, hydrants, or hauled water. James discovered that many of the black residents of the county used discarded 55-gallon drums, most of which had been used to transport chemicals, including DDT and other pesticides used on plantations to store water that they hauled from the municipal water supplies. Others gathered water from irrigation ditches. Even homes that did have pumps, James found, did not get clean water because the wells did not go deep enough. This is one of those drums. This is used to hold pesticides on the plantation. It's hard to see, but here's a spigot they put on it. So you've got water that even if you got clean water put in this tank, right, it's not going to be clean. And of course, usually they didn't even get clean water put in the tank. Usually it was water that they found in drainage ditches. And some places that had pumps, the pumps didn't go down deep enough. And what they did, these are two of my favorite pictures, and that's why I thought they were important to have. This is Sister Mary Stella, who was a midwife. I wish we had time to talk about her too. We've only got so much time. But one of the things that Andy devised was, he said, well, we can get clean water, but we got to get it farther down. And what they divided was a two-man pump team. And they took a 3/4-inch pipe, and this is a piece of telephone pole. And you just had two guys jam it down until they got clean water. And you can go through the Delta today. There's still orange-handled pumps that were put in this way. Eventually, they would get a pipe digging machine. But this was the creativity of Andy James and others saying, we can't have this system, so we're going to get two guys and literally bang a pipe down until we get clean water, put an orange pump on it, and now we can at least solve that one problem so people are not sick from bad water. The other problem Andy James found was sanitation. I got another little bit to read. In addition to the lack of clean drinking water, sewage disposal was a major health issue for the black residents of the region. When the health center opened, it was estimated that 90% of African Americans, 90%, living in North Bolivar County had no flush toilet. The most common methods of rural home sewage disposal was a sunshine privy, basically an outhouse minus a pit or rear wall. Small cesspools with no secondary treatment, little more than holes in the ground, served as the next most common system of home sewage disposal. It was just a bad scene to a person, to a sanitarian, to an environmental engineer to see something like this, James recalled. The negative health effects of such improper facilities were obvious, and providing both immediate and long-term solutions for the proper disposal of human waste became a priority for James. Faced with both the poor existing conditions and the extreme poverty of the area, James admitted that he had to shift my values down and initially focused on the immediate solutions to try and improve the environmental health conditions in the area. The immediate solutions is to build sanitary outhouses. This is the late 1960s. And his solution is, we have to build outhouses. And so they begin building outhouses. Now, that was not going to be enough for Andy James. And what he did, he and the health center, they entered into lawsuits. The ultimate case, the Supreme Court case is Shaw versus Mississippi, that said, if you have sewage disposal in one part of the town, you have to have it in all parts of the town. Because what you had is you literally, we talk about the other side of the tracks, right? White parts of Shaw, white parts of Rosedale had plumbing, had sewage disposal, black parts didn't. You literally had shit floating in the streets in Black Rosedale when it rained, at a time when we sent men to the moon and brought them back safely. I mean, this is not like it was happening back in the 1800s. And so, part of it was doing these basic things, but part of it was saying, we're going to go through the legal system too. And Andy James did it. He also helped organize boycotts, to make sure that the counties did. So there was a lot of activism. They had to be very careful with the activism, because there was a fear that it would deal with their federal funding if it looked like they were political. But they did certainly work for social justice and things like making sure that there was plumbing and sewage in all parts of the town. Another thing Andy James's team dealt with was housing. They saw that there was tremendous difficulties in housing, and of course health was related to that. The condition of people's homes was another obstacle for James and his team in improving health conditions, because the rundown condition of the shacks was often a health hazard in its own right. I would say 65 to 70% of all the housing in that area for black folk would simply be unfit for human habitation, James reported. In addition to seeing homes invaded by vermin, the health center regularly saw patients injured from falls through broken planks or off porches or without stairs. One of the most dangerous health hazards in many of these plantation shacks was a metal stove, which was usually the only means of heat. The first winter that the health center was open, Geiger staff saw dozens of burned children, which took them by surprise. Then they found the reason. People had tin stoves in the middle of their shacks, Geiger said. The kids were cold and got up next to it, and their clothing caught on fire. In response, the environmental health team designed and installed fences around these stoves to protect children from getting too close, and the burn stopped. This relationship between, figuring out just the home environment and solving these problems that they had not expected, right? They had been prepared for other things, and kind of like the dealing with old people or dealing with malnutrition, the housing issues became something that they had to change as well. There's that quote from Roy Brown as well. I know just a couple minutes left. I want to talk just briefly about the Farm CoOp. One of the most creative things that was done, although one that ultimately didn't work out as it had hoped to, was the North Bolivar Farm CoOp. And this was a brainchild, again, of John Hatch, but also something that grew out of Jack's experience in South Africa, where the Karks had developed community gardens so the children could eat better, so they'd have better nutrition. John Hatch said, well, why can't we do something like that here? As John and Jack used to say, we're on the richest land in the world with the poorest people in the world. Why can't we grow some food instead of just growing cotton and soybeans? So John Hatch worked very hard in trying to find ways to develop first a farm and then a co-op for the people to kind of grow their own food. This will eventually fail, but it kind of shows. I think it's a great example of the creativity. And part of the problem and part of the need is something we don't think about. The hunger problem in the Mississippi Delta was so acute, in part because of changes in federal policies. We think of the war on poverty and food stamps and things like that. The food stamp program actually hurt people in the Mississippi Delta, and that's going to be one of the impetuses for the Farm CoOp. So the problem of hunger in the Mississippi Delta was acute by the time of the Tufts Delta Health Center when it opened in 1967. At the time, 470,000 Mississippians received food stamps, roughly 10% of the national total. But due to rising entry costs of the program, many more poor blacks in the Delta could not afford them. Indeed, in 1967 Civil Rights Commission study found that 8 Mississippi counties that had switched from commodity distribution to food stamps experienced a decrease of almost 36,000 poor people receiving food aid. You had to pay for food stamps. You didn't have to pay for commodities. People actually got worse off as the food stamp program developed. And so John said, well, we need to do something about this. And and he develops the farm. At its height in 1969, over 300 people worked at the co-op in one way or another. Some earning cash with food for daily work on the farm, while others in both full and part-time positions worked in all aspects of the co-op's operation. Along with jobs on the farm itself, the co-op provided a number of opportunities for Bolliford County's poor. The frozen food locker employed a number of full-time workers, and others worked in the co-op stores established in Mound Bayou, Winstonville, Simons, Rosedale, and Round Lake. We set up co-op stores where the vegetables where the vegetables that we grew on the farm were delivered and distributed to members of those communities, remembered L.C. Dorsey. And a member was selected by the local community to run the store. So that the co-op provided not only some food aid, but it implied employment for people, and which was one of the ideas. Now, the co-op fails in part because they had difficulties making it work without having to switch to some cash crops, and that drove some people out. But it also suffered from lack of the funding that it had been receiving in the 1960s that goes out in the 1970s, which of course is something that's going to hit all of the health center in the 1970s. By the early 1970s, and we don't have time to kind of get into all of it, but there are a whole bunch of forces kind of coming down on the Tufts Delta Health Center. One is the beginning of the dismantling of the war on poverty with President Nixon's election, and the gutting of the programs that had been set up under the OEO. And the OEO itself, of course, will go away eventually. The other problems were some of the problems that Jack was dealing with in Mound Bayou himself. There had always been conflict over who was controlling this money, especially from those in the local Mound Bayou government. There had always been a lot of resentment of Jack and of Tufts, and it created a lot of problems that Jack can probably talk about later if he wishes. And all of these things came to a head in the early 1970s. Tufts eventually decides they're not, basically they had enough. Jack goes to SUNY Stony Brook. They take over the grant for a little bit, but eventually the grant then will go to Mississippi, and then it'll be cut. The governor, who had been trying to cut this grant for years, one of the ingenious things that was done under the OEO was the OEO to get support of Southern governors. All Southern governors could veto any OEO funding they wanted, because there was a lot of resentment amongst Southern governors to federal programs. So the governors had a veto power over any OEO program, unless it went through an educational institution. Of course, they agreed to this because they figured, well, they're going to go through their own educational. If it's in Mississippi, it's going to go through Ole Miss. If it's in Alabama, it's going to go through Tuscaloosa. They hadn't really thought about Massachusetts school running a program in Mississippi, and so that had protected Mound Bayou for years. Once that protection was gone, the governor cut the funding, vetoed this funding in the early 1970s. And so the 1970s saw a very dark time for not just the Tufts Delta Health Center, but by that point the nascent health centers around the country as we saw funding. And I said, just one quote here from, I think it's from Herman Johnson, I think. I don't know why his name's not there. Yeah, Herman Johnson, who started out at the health center and eventually then went on to run a lot of it, saw that they had to go to what Jack called a leaner and meaner model in the 1970s and 1980s, focused much more on things like those traditional vaccinations and treating people after they're sick, and not being able to do the educational programs, the nutritional programs, the environmental programs that they had been able to do before. And so while the health centers survived, they had to cut back on a lot of the very innovative programs that Jack and others had started in the 1960s and into the 1970s. But of course they did survive, and this is the Delta Health Center today, the new Jack Geiger building, which was dedicated, about 2 years ago now? 2 years ago. This, of course, Jack. This is L.C. Dorsey, who was, I mentioned earlier, Elsie came to the health center in 1967. She became she had about a 6th grade education. She had been a civil rights worker. She came, she got a job as an organizer and as a nurse's aide with the health center. She was eventually elected to run the co-op. She then was able to parlay that into going to SUNY Stony Brook and getting her college degree. She'd eventually go on and get a doctorate. And in 1986, she comes back and she ran the Delta Health Center. She ran it for about 10 years and really turned it around. Just one of the amazing people. And this was at the groundbreaking for this for this center. And unfortunately, Elsie passed about 3 months after this photo was taken. But you know, really one of the great heroes, along with Jack and John Hatch and Andy James and Bob Smith and the others that really did it. So I think I've gone a little over my time, so I'm gonna stop there. But thank you all, and I appreciate it. I'd love to talk to people afterwards.
I'm just blown away, you know, and as someone who spends my life working with community health centers, I learned an extraordinary amount reading the galleys before the book was actually the printed book that you see here today, and listening to Dr. Ward. Someone suggested earlier that we might need tissues. There's a box there, you know, if hearing about Elsie Dorsey and the work that Jack and John Hatch and Elsie did, you may need tissues. So what I'd like to do is, we have a terrific panel lined up today. Barbara Aaron, who's the terrific chief of staff here at the School of Public Health, reminds me that this is a seminar room, that there are actually students coming in after us and that they need to start on time. So rather than taking a long time to introduce everybody on the panel, what I'm going to tell you is that bios are in the program booklet, and please be sure to pick one up. It'll be a memento in its own right. Our panel is, of course, our guest of honor, Dr. Jack Geiger, Dan Hawkins, who you met earlier, Dr. Monica Sweeney, who today serves as the Vice Dean for Global Engagement and Clinical Professor at the SUNY Downstate Medical Center and School of Public Health, but is a former Health Center Chief of Clinical Affairs, and an extraordinary and wonderful longtime colleague. And of course, Dr. Warria Esmond, who is today Chief Medical Officer of Settlement Health Community Health Center here in Harlem, and has a terrific pedigree. So I hope you'll read their bios, and what we'd like to do is we'd like to kind of keep time with the panelists, invite everybody up, and then hopefully there will be some time for discussion and of course the reception. So let's welcome the panel, please.
So I'm stepping up now, and it's a big one. Okay, so the chair is right in front of me. The seat is facing your left. Certainly, or to get someone after. Okay, so I was going to, you got to turn. You got that.
Okay. Back and forth.
No, that's yours.
Oh, okay. So are we live? We're live.
Are we live? Somebody tell us when to start? Okay.
Start breathing. I tell you what, we'll start. I think we should start by asking Dr. Jack to tell us a war story, Jack. From the trenches.
What?
Well, the first war story is contemporary, and some of you have had occasion to hear me say this before. It's pretty obvious that for some time now, there's almost nothing left of my eyesight. But it turns out that you don't have to have good eyesight to hang on to a vision. That's what characterizes, in one way or another, most of the people in this room. The thing I think I want to say, is that better? The thing I want to say first is, what a celebration this is of Tom Ward's work. And he started from scratch. He knew the turf, but he didn't know anything about this project, and he worked for the better part, going on 4 years, to produce this wonderful narrative, which is not only a wonderful narrative, but a brilliantly researched one, that tells just about the whole story. And I don't think anybody could have done it as well or better over that period of time. And you got some sense in the things he wrote that he read to you of his own enthusiasm and understanding for the project. And his characterizations of the people who worked on it. I'm just going to add one word. As a believer in collective efforts, there was an enormous amount of contributions, editing, corrections, suggestions to him as each draft chapter was outlined and then started to be written and flowing back to him. And this audience has got a considerable scattering of people. A few out here: Marissa Sobelson, Zoe Stopak Bear, Tess Solomon, Ira Ahmed, and Abe Nelson were the people who did all of the typing, all of the suggestions, all of the editing contributions that flowed back to Tom that he had to deal with in finishing this book off. There is just no way to describe what a collaborative effort it was and how brilliantly he has done it and what kind of understanding of what this is all about. I had hoped, like everybody else in the room, that we would talk at this event about how to recreate in coming years some of the kind of social justice and social change work on the part of community health centers that had characterized not just the Tufts Health Center, but many of the earliest community health centers that were funded to reach in the same way that Tom has described to you, the reaching out beyond the provision of personal medical services and individual health care to start to alter the social determinants of health, which in the main are themselves politically determined. And I was looking forward to the ways, different than in the 1960s, but appropriate to our own time, that might happen. For example, if every community health center had a designated person working full-time to collaborate with municipal governments, with rural county governments, with agencies of the federal, state, and local governments on housing, on food, on transportation, on safe water, all of the things that we need to be working on. To give you just one example, there's a different kind of war story. The whole nation got outraged at the story of Flint, Michigan, where 7% of the children who were tested were found to have dangerously elevated lead levels. A community health center and a lawyer from Medical Legal Partnerships and the Public Health Department in Lancaster, Pennsylvania, did the same kind of study in Lancaster and its poor population, and found that 23% of the children tested had lead poisoning. It wasn't due to bad water, it was due to the crumbling housing stock and all the lead paint that had accumulated, the lead paint dust that was in Lancaster's low-income population, Asian housing stock, full of lead paint on all the interior walls. And the health center and the lawyer took a look and discovered that what passed for the laws controlling this were abysmal, inefficient, provided no incentives to landlords to do anything, no regular inspection, and no penalties. And they drafted a new law, took their data, went to the mayor, the city council, and most importantly, the public, and got 90% of all of those things incorporated in the new law. The follow-up study is not yet completed, but I know from the state public health department that the rate of children with elevated lead levels has absolutely plummeted. And that's the story that occurs in community after community across the nation. Many of them communities where we have community health centers, and that's a task that I hope we would begin. Instead, and I'm sure other members of this panel will address it, we are probably going to have to start organizing now for 2018 and organizing to make sure we preserve Medicaid, the Community Health Center Network, and all other such good things. Thank you, Jack. Let me turn it over now to Dan.
As a matter of fact, you reminded me of something just a couple of years ago. Dolores Huerta, who was one of the organizers with Cesar Chavez, Organized United Farm Workers, spoke to us at a conference. She's still around. And she said, don't think of your work as providing health care. Think of your work as community organizing. And that is what differentiates health centers from so many others. Each one of us here, the remaining three panelists, are both, we were warriors, some still are, on the front lines, but we've also benefited from that movement. Monica, tell us how you came into this movement and what you take away from it.
I'm Monica Sweeney, and presently I am the chair of health policy and management at the School of Public Health at SUNY Downstate. I left a private practice, which my husband used to refer to as a carriage trade, because I worked at Park Slope, and when you had a bill, you just gave it to them and they paid it. And left it and went to work at a community health center. I was volunteering essentially 1.5 days a week. And then they said, we need a medical director. And I said, but I've never directed a community health center. I don't know anything about it. And they said, you'll learn. And so I went to work as the medical director, vice president of medical affairs at the Memphis Stuyvesant Family Health Center. And I really loved it because I would see 20 or 30 people a day in my practice, for which I did all kinds of quality care. But at the health center, I got to do that and make an impression on care or direct care for about 300 people a day between our various programs. So I love that aspect of it. What I didn't know is that people live such marginalized lives in so many ways that just as in Dr. Ward's book and Dr. Geiger found out in Mississippi, although the poverty was not nearly as severe in the 1990s and 2000 when I was there, health was not their primary concern. And that's when I started learning about the social determinants of health. Because coming out of medical school, I didn't know anything about social determinants of health. In my private practice, I didn't learn about social determinants of health. In the health center, I learned that if it was the last of the month, you didn't give a patient who was on public assistance an appointment to come to the center because they wouldn't have money to come. You didn't get strict with people about appointments because the morning they were supposed to come for an appointment, they had to go to see about their child in school or not get put out of their apartment. So I learned all of those things through working at the health center, and we made ourselves work toward what was good for the patients, not our schedule at the health center. And that's one big lesson that I learned from the health center, that we were patient-centered, meaning we had to try our best to accommodate patients. And the other thing is, I learned that people want to do more. And the people that work for us at the health center were the same people as in the community. They also came to the health center for much of their care, except when it was something like HIV, because they didn't want anyone to know. But for their well child care and their physicals and all of this, they came to the health center. So I always love saying the people we are, the people we serve. And what I learned is people took great pride in working at the health center, and it was their source of income to feed their families. It was their sense of pride that they worked there because people would come in and see them there with their uniforms on and so forth, so they were proud to work there. And that when something went wrong, it impacted them personally, so they were motivated to help make it right. So I learned a lot of the lessons that I continue to use for the health center. And we were mission driven. And so we did all of those things that we said. We wrote a mission statement, a vision statement, and all of these statements. And whenever things would come up, I would say, well, we have to go back to the mission. And that was what we did. And I will close just right this minute because I know we're pressed for time. I don't like quoting people. I like making up things myself. This is said better than I could do it. Only those who dare to fail greatly can ever achieve greatly. And for Dr. Geiger and Dr. Ward, you dared to fail greatly and you definitely achieved greatly.
Now we have Gloria, who is still in the movement. Unlike the rest of us, are sort of a step away, or at least connected, but not directly. Tell us what brought you into the movement and what you take away from it every day.
I was telling a story earlier. My beginnings in the health center movement started before I even understood. My first job, my freshman year in college, was in the administrative offices of a demonstration project in Queens, where I grew up. And unbeknownst to me, my family doctor was the CMO. It was a different model where people volunteer their time to take care of the community. So my dentist was there, my pediatrician was there, the OBGYN, the delivery was there, the GI, you name it. It was this wonderful community. 30 years later, I ended up at Settlement Health. I always believed that healthcare was a right, not a privilege. I also believe that it was my job to do something to impact the healthcare of a community. I thought it would be my own community, but it's a community here in New York City, which is my home. So 30 years later, I read our competing application, and I said, where have I seen something like this before? And it harkened back to that summer I spent in that health center with the person who I think knew that I would one day end up in a federally qualified health center. So I have her to thank for having the privilege to do this work, because this is truly a privilege. And to have Dr. Geiger develop the vision that gave us this privilege, because that's truly, I think, what we're about. We are still those instruments of social change. Nothing has changed about the work that we do. We still need to be advocates. We still need to be involved in activism, and we do. What I do believe is that we're not just a healthcare provider. People like to call us clinics. We're not just a clinic. We embrace the work that we do. We embrace the patients that we take care of. And we embed ourselves in the community in which we reside to make sure that our patients get access. Social determinants, there's nothing new there either. We're still dealing with housing. We're still dealing with food. We're still dealing with safety. The differences are, we've had some in the book when we get the opportunity to read it. There's some wonderful stories about people who've evolved, like we've heard about today. It may not be the same patients you're taking care of over the last 50 years, but they're the same type of patients that you're taking care of, with the same needs, different cultural backgrounds, different beliefs. And we're still fighting that fight, right? We're still digging in. It's like an honest. Our tools are more electronic and more technical, and we've got access to a little bit more of the world than India had down value in 1965. But we're still struggling with that technology to reach the people we need to reach. What's interesting in hearing Dr. Ward speak and it occurred to me is in our efforts to innovate, we don't realize we're simply recreating what was done 50 years ago. Community nursing, we're coming back to the point where we realize we need to meet the patients where they are. Right? Like we can't take care of them just in the walls of our health center, but that care needs to be in the community, observing where they are, supporting them where they are, just the way the community nurses did back in Mount Bayou. We still have patients living in substandard housing. We have them sharing multiple families in one unit with no access to cooking facilities, forced to eat out, use their limited resources. So we don't have the sanitation issue, but we have other issues that impact health. And just to speak, Dr. Geiger, the medical legal partnership, I think, is a critical piece that we need to really develop because all that we're trying to do has a legal and political implication to it. We've got to partner to make this happen. There's so much to say. We could spend 5 hours here. I will end there because it truly has been a privilege to do the work that I do, to fight at the state, local, and national level for the rights of those who don't have a voice.
Thanks very much. I just want to tell one snippet because I too have been moved by the movement, affected by the movement, and spurred on by the movement. When I started as a VISTA volunteer in South Texas in the late 1960s, I didn't know what I was doing. I was a 22-year-old kid, just got out of school. I knew I didn't want to go to Vietnam, so I signed up for VISTA and went there for a year. 10 years later, I finally left. But the key was I learned the art. There is an art, some science, but mostly art of community organizing. And when we brought the community leadership together, we found that cream that rises to the top. I don't care how economically and otherwise direct the community is. There are leaders that others look to. And we found them. We brought them together. We said, what do you need? And they said, this is South Texas, okay? Healthcare, kid. Go get us something. So we went off and looked and found a program. They said it in Spanish, of course. But we went off and found a program called Migrant Health. That was home based for a lot of farm workers. And with the help of a couple of public health professionals, wrote up a grant application, sent it off to Washington, D.C., actually flew up once and lobbied. I wish to distribute lobbying our members of Congress. And about 6 months later, in came the grant award. So I proudly walked back the grant award and said, here's your health care. They said, that's nice, kid, now we'll run it. Muy bien, joven, ahora diríjalo. That's what I was told. They said, what? I'm 22 years old. I don't know squat about healthcare. I can't manage myself. You want me to manage a bunch of people? Forget it. But I did, and it set the path for my life. I have never been out of the health center movement since. Went from the front lines to the general extent, if you were, Joe Califano's office as Secretary of HHS during the Carter years, and now I'm out fighting to make sure these guys get more resources and we can grow this program to serve more people. That's been my life's battle. As yours is every day, providing the care. I get you the money you put it to use. And one last thing, I always maintain, I told all of you this many times over the years, that the best thing my health center did for its community down there in South Texas was not the medical care that the 4 docs and the 12 nurse practitioners and the 14 nurse midwives provided. It wasn't the 2 birthing clinics that lowered the infant mortality rate there by 2/3 within a couple of years. It wasn't the mobile clinics. It wasn't the home health agency. It wasn't any of that. It was a potable water and sewer supply system that we convinced another group to apply to HUD EDA, Economic Development Administration, to run in water lines and sewer lines down the paved, unpaved, streets in these rural colonias, villages, in the outlying area, because they heard, the board, my board, had heard enough from my docs, the health center's docs, about all the upper respiratory and other kinds of problems of the intestinal problems that the kids brought in as a result of not having access to clean water and clean sewage and sanitation. That was the best thing that my health center ever did for its community. It wasn't the 40,000 people we served. It was that system of service that made life better for that community. And I think that's the story of health centers. Jack would say, that's exactly what we wanted you to do when we started this whole thing. Yeah, catch up the folks and make them happy and send them off, but do more than that. Change things for the better in the community. And that's what it was all about. Now, I think, Vega,
Dan.
I think it's your turn to close it up.
All right. So actually, we're not going to close. We have some time for questions, not too much time, but a little bit of time. So if there are any questions, we will pass around the mic and give you an opportunity to address some additional things. And also, I should say, I want to just, Anne, before I recognize our New York City Commissioner of Health, who joined us a couple moments late, but we're really grateful that she can join us. So, Anne, why don't we start with you? Oh, great, Paolo, and then we'll pass around the mic.
What was described, hi, I'm Ann Nolan from Hudson River Healthcare Community Health Center Network in Hudson Valley and Long Island. Been there 40 years, so been through a lot of this, but not quite as early as the reference to the early 70s. And when I think you must have ducked, you got leaner and meaner to save the Community Health Center program. And I'm interested in how you did that as a potential strategy for what we look forward to in the next few years.
Actually, I think you could tell some stories too, what you went through. I will tell you that in Washington, what we had to do, and we organized a fight to save the program, save the resources coming in. The wonderful thing is we had community ownership. And one of the things I've always said is that community boards will protect their health center and fight like hell to keep it alive when it's under duress. And we found that when we went out, there were only 350 health centers in 1980, and they were serving less than 5 million people. And yet they mounted an effort that convinced people like Will Geiger, Bob Stafford up in Vermont, these are Republicans, by the way, in the Congress, to oppose President Reagan's budget resolution that was going to block this program into oblivion. And there were others who did that and fought the good battle. We're going to have to do the same thing. That's community organizing. And we are going to have to find, we've enjoyed bipartisan support. Now it's time that we go up to our friends in Maryland, our Republican friends in Congress, and say, this is a test of your friendship and support. What are you going to do? I believe we'll win that fight. I truly do. I'm an eternal optimist. But I believe it because we're even stronger than we were back then. We've got 25 million people on our side. We've got 35,000 community board members who own and operate those health centers. And we've got 200,000 people who work at health centers today. And I dare say they will rise up. And to use an old term, smite the enemy. That's what we've got to do.
It always works best when we involve the patients. The legislators barely want to hear from those of us who work there. But when we get the patients activated, I will just tell you, when the Republican convention was in New York several years ago, I don't remember which year exactly, and they came to Memphis-Stuyvesant Family Health Center for a visit, the patients all, without being prompted, without rehearsal, without anything, went to the Republican, Rick Santorum was one of them, and said, you have to make sure that this community health center stays open, because this is where all of us come to get our care. And so when one person saw one person talking to the senator, then another one came over, said, I have 5 children, and every one of them I got my prenatal care at this center. So I don't know why you're here, but make sure that we keep, and this was what went on until he left the center. So when you get the patients involved, whether they come and do it. Remember those, like cream rising to the top?
Mhm.
There are people who will just do it out of necessity. They think it's necessary to do it, so always keep the patience in it.
I would say out of love for the community. I mean, I've always said that's why community board members serve. They don't get a penny for their work, but they do it because they care about the community. And that is why I always say the community board members are among the most powerful advocates for health centers all across the country.
And their patience.
And their
And their
patients,
patients.
absolutely. No more questions.
More questions?
Well, we either answered everything or maybe not. I don't know. Hyman?
You've talked a lot about social determinants of health, and I think, Jack dealt with social determinants of health before the term was even coined, giving food prescriptions and the like. But in this current moment of, I don't want to call it crisis, but challenge, how can this movement reach out to partnerships outside of the healthcare delivery system in order to mobilize action that is directly involving individuals and communities and their health? I think we have less of that than we used to, perhaps, or that we need to rethink it in a way that's important. And the other question that dovetails with Anne's question is, how can we mobilize informed volunteers? There is no question that there is the risk of reduction in resources over the next couple of years. And to wait till the moment of crisis is going to be too late. Outside of political mobilization, as you suggested, is there a way for us to start activating volunteerism in an informed and supported way?
Well, I'll respond to a part of that at least. I think a lot of this is, there are kind of two sets of people and resources and organizations. One that I've mentioned, which is all of the existing municipal, state, or federal agencies, the people in housing, the people in transportation, the people in HSS, obviously, who deal with aspects that are beyond the mere provision of personal medical, individual medical care and health services, and dealings in addition with these powerful other determinants. But there's also a great set of non-governmental organizations, and we should be forming formal coalitions, active coalitions, talking to them, having them talk to us, coalitions to respond to the things that we will confront. And I quite agree with you. We should be doing that now. We should be doing that before the 2018 midterm. We should be doing that before the crisis is upon us. We should be reaching out to, for another example, educational NGOs tied to the kind of housing segregation and public school segregation that shames the city. And one of the projects that I talked to Dan about and that I'm beginning work on now is, as the National Association of Community Health Centers has done such a good job of documenting the economic impact of community health centers on its patient constituency and on its community economy. I think we need to now start documenting something that hasn't been as prominent, the enormous educational impact that community health centers have had on the communities they serve and on the upward educational mobility of the people we train and intern. I talked to a woman not long ago who started at one of the community health centers as a switchboard operator. and she is now the CEO. That's what we're about as well, and we need to be reaching out in that segment too.
Well, I feel embarrassed because I missed everything and I'm still here, but I'm very glad to acknowledge that I have some members of the department, Dr. Lisa Maybank, who heads our Center for Health Equity, and some of her team, the Assistant Commissioner who's based in East Harlem. And I wanted to just ask you all to tell more stories. You told us your story, but one of the things that I've always heard, which struck me so much, Jack, when I saw your YouTube clip, which many people in the health department have watched, called Out in the Rural, is the fact that people who entered the orbit of your clinic and often went on to gain, additional training, became healthcare workers themselves. Their parents may have been nurse aides, they became doctors. The people who worked at the Martin Luther King Clinic in the Bronx tell the same story. Community outreach workers, the next generation were, administrators, and I agree that that's a richness that we need to maintain that part of the story too. So if any of you could just comment on that, it would be great.
In Bolivar County, the median educational level of Black rural residents was 5th grade in miserable segregated schools. Nevertheless, by the end of our first decade there, we had 7 people in medical school because there were folks around and there were folks who came back. And granted, it was the aegis and the era of the civil rights movement. We all leaned on our alma maters. There were ways to get cooperation in that, and we're going to have to reinvent some of that. In the foreword to the book, Tom Ward quite proper. Tom Ward, I think I read a foreword, and I did, and in there, as he had designated John Hatch as the soul of the Delta Health Center, and John said, in effect, the most important thing we did with the people in the communities we work with, we changed their dreams. We changed their aspirations. I can't think of any work of community health centers that's more important than that for us to restore and keep back. It's not the Mississippi Delta. We're not all alone. There are lots of other agencies and NGOs and departments to work with, but this needs to be part of all of our work, not just in community health, but in departments of public health, like our own in the city. That's a longer range pathway to change. I'm not going to start citing figures. I will tell one more story, with apologies to those that have heard it before, that needs to be, in a way, a guiding principle for what we all seem to be agreed on as we head into these next years. And that is the need to push the envelope. And the war story that goes with it is when the people from the Farm CoOp came to me and said, we understand that you're a city boy and don't know anything about these kinds of things, but if you want to have our first 100-acre Farm CoOp crop, we have to have 2 40-horsepower tractors and a backhoe by tomorrow morning, the day after, otherwise the land won't be prepared. And I said, okay, we have rollover money in the current grant. You go out and buy them tomorrow. The new grant renewal is going in. We'll stick the tractors in the backhoe in the renewal grant and pay the original grant back. And then we know later we're going to get a Ford Foundation grant. It's on the way. We'll pay the whole program back and it'll all be legal. I said, okay. And writing the new grant, the people just finishing it said, well, where do we put it? And I said, you know what? They never look at the capital equipment section down at Oklahoma. Just stick it in there, somewhere in there. And they did, and we sent it in. And And of course, that was the year that they looked at the Capitol. And the way I discovered that was that I got a kind of deadpan call from OEO, because it turned out they had stuck the tractors in the backhoe right in the middle of the obstetrical supply. And I got a call from OEO asking what kind of delivery.
What size baby did you
But the real point is what Dr. Sweeney just cited. You take risks, you take gambles, you go out on these kinds of limbs, and sometimes good things happen. And I'm with Dan and optimism. I think over the next 2 to 4 years, we are nevertheless going to make some good things happen. And I plan to hang around for it.
So, Jack, can I just take this mic out of your hands?
Yeah.
Okay, so we're going to bring the formal part of this program to a close. I just wanted to make 2 comments. One to the panel discussion that we had here today in terms of the extraordinary need that we face of forging those collaborations, forging those partnerships, really taking much more expansive view than many of us have been able to take in recent years as we face retrenchment. I know that, like Jack, when we were